Welcome, everybody. Happy New Year. This is our first webinar for Penn AI Tech for 2025. Penn AI Tech is the Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging, an initiative funded by the National Institute on Aging at the University of Pennsylvania. Today, we're very excited to have with us our guest speaker, Dr. Marjolein den Ouden from Saxion University of Applied Sciences in the Netherlands. She's an epidemiologist and a movement scientist and a professor in technology, health and care at Saxion. And we want to remind everybody that you can use the Q&A feature if you have questions. And upon completion of her talk, we should have some time to answer questions and discussion. Without further ado, thank you so much, Dr. den Ouden. I turn it over to you.
Oh, perfect. Thank you for the lovely introduction. And I'm going to try to share my screen and start the presentation. Probably you see my my slides by now. So as George said, I'm the Professor of Technology, Health and Care, both at Saxion University and the Regional Community College Twente. And today I'm going to present some of our work in order to have a transition from healthcare professionals versus technology to healthcare professionals using technology or with technology. And just to get a scope of where I'm presenting from, I'm one of the researchers living in the Netherlands, so quite a distance from the USA. And currently I'm in the spotlight because we have, it's now 6 o'clock in the evening. Just a really short introduction about our university. So Saxion University of Applied Science is really mainly driven about the implications of technological innovations that will change the world. And we do this by education, doing research and entrepreneurship. And our goal is to get ready for a smart world. So that is, from many different disciplines, we try to see what the added value is of using technology, both in the health and care domain, but also within communities, in entrepreneurship. So quite a far-reaching scope. And we do this by our profile on living technology. So we really want to connect the knowledge and the technology to contribute to a sustainable, healthy, and safe world. And we're an applied science, University of Applied Science. So we really want to put people first and along with the issues and the consequences for society. So we try to translate insights of scientific research into practice. And in this, probably it is not that different than the USA, but I wanted to set a scope on why I do this research. So I think both in the USA and in Europe, life expectancy is increasing, but also the number of people with one or more chronic diseases increases. So it sets a challenge on both sides. And especially in Europe, we deal with increased cost, but far more important is that we have a sort of staffing crisis. In the past, more staff was often the solution. So more healthcare professionals, doctors to compensate for the increased demand of care. But nowadays we have not enough available people wanting to work in healthcare, but also not available young professionals who are present to set up this work. So for our country, for example, now 1 in 6 people works in healthcare. If we want to challenge the life expectancy and the chronic diseases, it would mean that 1 in 4 people would have to work in healthcare, and that is not sustainable for the future. In addition, we try to compensate with more, asking more of informal caregivers, but that is not the two sort of keys to tackle these challenges. So we really want to see how we can transform our healthcare, and it is definitely needed, not in 10 years, but actually, for example, in a year or a much shorter horizon. And we see that in the emissions of the European Union as well. So an aging population, the increasing burden of diseases is really affecting a patient and innovative healthcare. But the main challenge that we foresee is that there's a really slow pace of digitalization and the uptake of new technologies within our healthcare systems. And also in the Netherlands, we see that the government sort of states that their ambitions that by 2040, all Dutch citizens should be able to live 5 years longer in good health. So really focusing on prevention. And additional goal is to decrease the health inequalities in our country. So the differences between the lowest and the highest socioeconomic status groups should be decreased by 30%. And that is really a radical change for our healthcare systems. And as you see in this figure, we put more focus on what people themselves can do together with their close relatives and friends. So more self-management and co-management with informal support. And within this circle, also technologies and new therapies are developed to tackle our challenges. And in this presentation, I want to get into the scope of how can we really transform the perspective of healthcare professionals to see technology as one of the added values they can use in order to deliver relevant, good care, instead of seeing it as something that sort of counterbalances their professional attitude. And in this presentation, I want to have, I won't go into detail of one specific topic. I want to touch upon 3 different topics. So the role of patients and professionals in human-centered technology development is one of the keys to tackle these challenges. The technology competencies that people should be, that healthcare professionals should have, and different approaches to education future-proof professionals. For example, we see that we have less people available, but also less professionals available to train new professionals. So we really should focus on a paradigm shift on the traditional way we educate our students. So these are the 3 topics, and I will illustrate them with several projects that I worked on. So this is one of the perspectives that we take into account in our research. So tell me and I forget, teach me and I will remember, involve me and I will learn. And especially on that 3rd topic, we really highlight and want to be contribute to innovative approaches to work together with professionals and clients to innovate our healthcare system. And one of the examples of this collaboration with end users in both the development and the implementation of technologies, with end user, I always see both clients and patients, so the direct end users, but also the healthcare professionals that help clients and patients to their new routine and the collaboration between them. So this is one of the perspectives that we use. It is in Dutch, but just to illustrate that sometimes it's difficult to see how a new technology should be implemented and integrated into the care path. And especially with new innovative approaches, everyone thinks highly of this innovative approach, but it should fit within the care path and how professionals collaborate together. So often we make it a visualization about the current care path, the barriers of that, and the possibilities to really integrate and implement new technologies. And for example, you can do that with a stakeholder analysis. So which type of stakeholders are involved? How do they collaborate in the current practice? And how, what types of barriers should we overcome? And that is sort of the analysis between the current situation and desired education situation. And for us in this integration in the client journey, the technological advancements and the social innovation go hand in hand. So you should not only develop new technologies, but also try to shift the paradigm and the competencies of professionals as well. And this is a client journey just as an example of a new technology that we developed for children. So for example, we recently finished a study on the wearable breathing trainer, which is, and I'll show the technology in the next slide, which is developed for children with dysfunctional breathing. For example, children with asthma or with hyper dysfunctional breathing. And in the Netherlands, children are treated by their pediatrician and their physiotherapist. And in the two photos, you can see that they sort of help the children to get a grip on their breathing pattern just by laying their hands on their tummy and trying to relax them and educate them about desirable breathing patterns. But we see in practice that the training at the physiotherapist is okay, but once children and the parents have to train at home, that is not done according to the guidelines of the physiotherapist. For example, it is boring. I just want to go out with my friends and not train at home. Or it's not done correctly as the physiotherapist learned them. In addition, we see that it is really difficult for children to transform this new breathing pattern. It is okay when they're laying or sitting, but it is more challenging when they do activities or exercise. So this is why we created wearable breathing training. So it's sort of a shirt with integrated sensors, which is based part on AI as well. And we developed two types of prototypes. So a functional prototype that is used for usability studies. So this is a boring example of the wearable breathing trainer, and it is in black. So we as researchers really can learn about how we can stimulate this breathing pattern and like which types of sensors help children to get a grip of their breathing pattern. On the other hand, we also work on an integrated prototype. So how should it look? How should it feel? And this was this design on the right was developed together with children themselves. So what kind of colors should they have? What kind of specifications should the prototype have? And then you see a much more nice design. The example is that children can wear this under their clothes, and the sensors are integrated into the shirt, and the shirt actually reminds them with haptic feedback about relaxation and really breathing pattern towards their stomach. And I think these types of studies is both on the functional design, so what types of sensors should be integrated and what kind of data should be on the output of the children and professionals, but also how can we teach children about the use of these types of technologies. And then we make use of these types of animations, not only telling them how they can work together with this technology and the physiotherapist, but also as a reminder what steps they have to take and to read through it at home. So this was an interesting project in which we closely collaborated with both children, their parents, but also with the involved healthcare professionals such as the pediatrician and the physiotherapist. But in addition, also to how can we make this as sustainable as possible? How can we reuse it in different settings? What types of, if children wear them, how how these breathing sensors are not broken after the first time use. So that is really an example of working together with the end users to see for new technologies that can be used to really take part of the jobs of healthcare professionals. On the other hand, a different example is a technology that is more based on AI, which is VIVA400. And you can see in the photos that VIVA400 is a digital personal assistant. For example, it can help, in this case, older adults in video calling, a personal agenda, medication reminders, reading the news and games. And the AI is integrated into the speech recognition, speech synthesis, avatar rendering, and the deep learning. And it is a personal assistant that speaks the same language as the people who use them. For example, the Dutch language, German, Italian, and English. But in this test, we try to test, improve, and implement a Turkish version in collaboration with end users. And I want to go into a bit more in depth about our study. So we, for example, did a qualitative study using a citizen science approach. And for us, it was one of the first studies in which we really collaborated with end users in a different perspective. So before we saw them as responders, we used focus groups, questionnaires to get input of the end users. And then as a researcher, we did the analysis and a conclusion of all the data. In this study, we really collaborated with people with dementia, so an early stage of dementia, as co-researchers. So we really involved them in setting the research question about which methods should be used. They reflected on our first analysis of the results. So we really performed this study in close collaboration with the end users themselves. So we saw them more as an expert panel, and in total 13 older adults and 3 healthcare professionals participated. And this was interesting for us as well, because normally in these types of studies, you get participants who are really open or much more a front runner in the use of technology. And in this group, we saw that none of the participants knew or used an assistive technology similar to VIVA400, but also in general, they did not use that many types of technology. So really a group that is open to new experiences, but not, we can see this as more of the general population of the Netherlands. And when we held the interviews and focus groups, we saw that people saw the advantages of VIVA400. For example, of the initial additional assistance of healthcare professionals and their families, there was really a decrease in the task and stress relief of healthcare professionals and their families. So the reminder of appointments, or for example, medication was done by Anna instead of a family member who had to remind them of these types of appointments. And for the clients themselves, it was a sense that there was someone in their home. So from a positive perspective, they had someone they can talk to. So the amount of the loneliness feeling was really interesting. And one of the advantages was that they were able to speak with Anne in their native language. So they, in the past years, they spoke Dutch, but due to their dementia, they were much more open to communicate in Turkish compared to the Dutch language. And one of the respondents really quoted this as, "It is really useful. VIVA400 tells me when I must take my medication. She helps me to remember, but she's also tough and fun, and I'm happy with it." So that's sort of portrays the added value of this VIVA400 for this individual. On the other hand, we saw that Anna took some time to set everything for the healthcare professionals and the family members. So the first introduction took more time than expected. On the other hand, there was a connection problem. For example, if an older adult and their family both have an iPhone or a Google phone, then they are not reliant on the type of device. And this Anna for Care is a prerequisite that both callers need the device. So that is one of the barriers. On the other hand, they see that clients saw that they expected real interactions with Anna, as it is a fellow human that was talking to them. But Anna could not foresee that. So, for example, one of the participants said, "We cannot talk together because she does not respond. Every morning I hear good morning, but that's it." So there were higher expectations of the technology than the technology could actually deliver. And one of the final challenges was the really dependence on the internet connection. Not every participant had an internet connection. So for the study, we gave them this internet connection, but this is one of the barriers if you want to implement it in a larger scale. And Anna could only be used inside home and not outside. So we see that by introducing new technologies, new barriers or challenges come up that you have to work together on. And this is why we do a lot of research, how we can get from a technology as a gadget to really integrate it into a care intervention. And these are some quotes of one of our participating research organizations. So I think we're at 25% of the possibilities of technology use, and we have to strive for this 100% due to the societal challenges. Or how can we really not only include the early adopters in these types of studies, but also in the implementation part. And we see that every setting or every care organization asks for a different blueprint or implementation strategy. And that is why we worked in the last 2 years with 3 care organizations on the implementation of technology. So the organizations themselves selected a technology that they want to implement in their organization. In addition, some teams already worked with this technology, but they saw much more to come, and like the increase of actual use is something that we strive for. And we used the NOS framework for this study. So the NOS framework might be familiar for you guys as well. So we see that the NOS framework is a sort of an interview guideline on what are the barriers and opportunities for technology implementation. And then you have different domains in which you focus on these barriers and opportunities. So both the conditions, so what is the end user of the technology themselves, the value proposition, so the added value of using technology over the current practice, really the adopter system, both staff, patients, and carers, the health care organization as a whole, and the wider system across the Netherlands, for example, or within a country, but also the change over time. So these types of domains, we collaborated with 3 care organizations and really get an in-depth insight of what the actual barriers and opportunities were. And we did this by using several research methods. So for example, we use data collection via focus groups. So focus group discussions, for example, we showed the NOS framework and systematically addressed every domain and see how these domains impact the actual use of technology. We also collaborated with the research, with the institutes on participatory observation. So one of the researchers followed some healthcare professionals to see how they actually use these types of technologies in their daily practice and observed them and reflected with them. Once we had a first idea about the barriers and opportunities, we had additional interviews to reflect and on our first findings. So in total, approximately 83 professionals participated. And for these 3 different healthcare organizations, we saw that actually although the type of technology was different, that the drivers or the barriers for technology implementation was quite the same. So you have to have an optimal match between the technology that was used and the question and intended use in practice. They saw quite gaps between the knowledge and the skills of professionals and clients, that they needed additional training or education, but especially time to get familiar with technology. And one of the more things that healthcare professionals needed was to create support by super users, not a department that is at a distance helping them with the implementation, but really someone in their team as a super user who you can contact when you have a problem and really on the job can learn together. And they saw some opportunities to really involve professionals in the development and technology implementation. So not from another department, but really helping them to tackle this challenge together. And that is why I wanted to make the step to the general technology competencies of healthcare professionals. And in the Netherlands, we struggle with technology is quite a broad topic. You can use virtual reality to AI to data-driven healthcare. And what types of technologies should healthcare professionals have? And that is why we did a Delphi study just before the COVID pandemic to identify the essential technology competencies of healthcare professionals. And in this expert panel, we got the perspectives of nurses, innovators, researchers, managers, educators. So in total, 64. And we had 3 different rounds. So in the first round, we focused on the technology competencies that were identified from literature and an existing framework. And we asked participants to rate these technology competencies on a scale to 1 to 5 about the importance of the competency. And already 13 of the identified competencies were included as very important. In addition, the experts were able to add to to give their input and on additional technology competencies. So in round 2, we focused on these 2 additional competencies that were added, but also whether the description of the competencies was clear. So that resulted in 88%, so quite a high score, were already very clear. And in the final focus group, we sort of saw competencies that everyone should have, sort of the basic competencies for healthcare and social workers, but also some more advanced competencies that not every professional should need, but like the competencies that the front runners or the super users should have. And this resulted, and it is a Dutch model, we're trying to translate it into English as well, but this resulted in what we call the V model for technology competencies, in which you sort of have a big layer of basic competencies. You should be able to, you're able to change your way of thinking and working. You should be able to find new technologies or know what is available within your organization or within the region. You should have the confidence to use it and be able to really have a skilled use about it. So not only finding it, but really able to use it in practice. And finally, you should be able to explain the use of technology, for example, to clients. So thereby taking this perspective in account as well. So these types of technologies are now integrated in all the curricula of the social work and the nursing education of the Netherlands. And they use this model to guide their curricula. In addition, we have some people who really are the front runners of this technology. So really take the lead, really active immersion about new technologies, trends that are coming. So looking forward to the future. They should be able to connect with different disciplines, but also with companies that portray the technology. They should be able to inform their colleagues about these new trends and how to use them skillfully. They have the job to think with professionals about the improvement of technologies. And finally, they should be able to really replace old technologies or really old strategies to deliver care. And you see there's sort of a ring on ethical reflection. So in using technology, you should always, as a professional, ask yourself the question whether technology is in this situation for this specific client actually a solution for the problem, or whether you have other opportunities to answer the question. And this formed the basis of our curricula, but also how we see the technology competencies of professionals. And last year, we saw that, for example, as the topic of this sessions of seminars is, artificial intelligence is much more one of the solutions. And by working together with artificial intelligence, this also reflects on the role and the function of nurses. So therefore, we thought, do we have a new digital co-worker as when you collaborate with artificial intelligence? So you not only have your own clinical expertise or the preferences of the client that you take into account, so the human input, but by integrating sensors, for example, in the living environment of clients, you also get input from sensors, which are integrated in algorithms and are presented to you as data. And these types of input, both from the client, yourself as a professional, and the presentation of new data, sort of ask something of this professional. And we recently published this article on our perspective, like a position paper on the collaboration between nurses and this new digital colleague. In addition, we performed an additional Delphi study, so to identify the essential competencies of nurses required to work with AI-driven lifestyle monitoring. With a similar expert panels, both nurses, innovators, developers, education, and we had the same 3 steps in our Delphi method. And it is interesting that we got a long list of sub-competencies and competency domains that were the result of this Delphi study. So we tried to put the findings into the general process of healthcare. For example, people should have basic understanding of AI. Some should be able to co-develop and really get input into the development of AI. And then more as a nurse, you should be able to focus on a needs assessment, how you can use the AI to personalize the AI or the findings of the AI to the client that you took care of. You have to integrate it into the report, be able to interpret the data that will come back to you as a nurse. And you will have to integrate these new types of data into the clinical practice and the perspectives of the clients as well. And by that, you sort of have a first grasp of how you can integrate it into clinical practice, and you should be able to communicate this with both professionals, but also with the clients and their family members that you take care of, and thereby implement it into a strategy and as a nurse. And of course, as every intervention, you should be able to evaluate it. And I just touch upon it really briefly, and we hope that we can publish this study in the next month. But this sort of gives a new topic. So this is another technology that really shows that other competencies are asked of nurses. And that is one of the questions that we address in the discussion as well. Is it overwhelming that you have to have 61 new competencies, or is it like a different approach of current competencies? So for example, as a nurse, you already have to make use of data. Only the type of database is different now. And finally, I want to touch upon a new approach to learning, and I want to address the Dutch project. And this Dutch project is introduced by a video.
In the Netherlands, patients have to wait longer and longer to get the care they need. Our healthcare system is slowly being overwhelmed and waiting lists are growing. So we urgently need more healthcare professionals, but we lack the capacity for in-practice and on-the-job training. Meanwhile, the demand for healthcare continues to rise. Putting even more pressure on hospitals to train new professionals won't work. So what does work? Virtual, digital and physical simulation significantly increases our capacity to train without adding pressure on clinical practice. This not only benefits the professional in training, but also their teachers and supervisors, the team that needs reinforcement, and ultimately the patient. Simulation is key, but also expensive and complex. Meet Dutch, our collaborative approach to develop the future of healthcare training in the Netherlands. We will build on top of what we already know and have, and create new resources and solutions to provide a comprehensive ecosystem that can be used effectively and everywhere. This way, we increase our ability to train new professionals, reduce the load on our hospitals, and work towards dissolving waiting lists. Want to learn more? Take a look at Dutch.technology. In the Netherlands.
Yes. And then it is a really innovative approach and with high ambition. So the goal of this project is a nationwide project in which all universities, all hospitals and all educational institutions work together to train new professionals, but also the perspective that we want to implement 50% of our educational program, both in practice and within the educational organization, will be transformed into simulation-based training. So both virtual, but also physical simulation. And we see this one of the solutions about the staffing problems, because we don't have sufficient staff to train new professionals, but also make efficient use of really innovative virtual reality approaches. But in the first year, we started last year. The first year was large stakeholder analysis that we did, because 50% reduction of actual practice hours as a total shift of professionals and educators. And we really have to have a ground that we want to transform this type of education. So in the last year, we did a stakeholder analysis in which we use different types of methods. For example, scenario sessions, and in which we ask students, educators, and professionals to really think of future scenarios. What is relevant? What are their feelings? What are their values with it? And we did it across the Netherlands, including important national institutes such as the government and companies and industry as well. In addition, we did interviews about what are your experiences with simulation-based training, or what are the opportunities or risks with this type of training. And finally, we try to collect and synthesize these data in a stakeholder map, different personas that you should adhere to when developing new virtual reality or simulation-based training, user requirements for this, and a business model canvas. And I will only go into detail about some of our results. So this is interesting that the values that were in general important for both professional students, but also policymakers, is that there is a safe environment to train. You should be able to trust that they have the opportunity to learn within this virtual environment. You should be able to make mistakes and learn from that. Eventually, the virtual or the simulation-based training should really add to the professional skills. And it should be a positive experience for the trainee. So, for example, have relevant feedback and appreciation about the process. And it really should be able to strengthen the collaboration between different organizations. And I just wanted to highlight the perspectives of professionals in this. So, for example, as every study, professionals saw opportunities. For example, a stronger connection between theory and practice, that you're able to learn from day one of your education in this simulation-based environment. That there is a safe learning environment. You should be able to make mistakes without negative consequences. Sometimes the virtual environment provides the opportunity to train situations that don't come across that often in real life. And the hope is, of course, that by training in this virtual environment, that you are able to make a stronger connection or faster connection when applying these competencies in practice. On the other hand, professionals saw some risk. For example, how do you know that this simulation or virtual environment really reflect the actual practice? In addition, by training on the job, it is not only the competencies of students that are trained, but they're working on team connection as well. They are sort of a bit hesitant whether the introduction of virtual simulation does not ask that much of their supervision as well. And for example, there are many financial concerns from more the peripheral hospitals. So this is an important topic that you really need each other to really transform healthcare education and healthcare practice. But within this transformation, you should always take the risk and the opportunities in the design of this new study, and that is why we did this stakeholder analysis. And it is not that this is totally new, because, for example, at our university, we already have an extended reality hub for both healthcare and social work. And we actually train our students to be able to, for example, they feel how, for example, people with dementia come across their environment, or train some skills in virtual reality. But the ambition to really make 50% of our practice hours in virtual or physical simulation, that will ask a lot of transformation of our current curricula as well. And that is why I wanted to come to the conclusion and recommendations. So for me, the end user involvement is really key for the implementation and integration of technology in healthcare. And I gave some examples how we do that and really collaborate with each other to not only have a positive side on the integration of technology, but really see the barriers as well. And professionals and their competencies are one of the solutions for the transformation of healthcare. They're the ones who really have to change their way they do their job. And that is why we see the added value of technology or not. And I think as an education, we really should be open to these innovative approaches to learning to really educate our future-proof professionals. So this is just a short introduction of our work, and I can imagine that there are some questions. So I'll give the floor back and be happy to answer.
Thank you so much for this great presentation. It was really exciting and stimulating to see these examples, and I think we can find a lot of relevance and potential application areas in the same populations that we try to design for here in the United States.
Yeah.
There's quite a few questions already in the Q&A, so I'll start with some of those, but also want to remind our participants, if they have questions for our speaker, to go ahead and use that feature. So the first question was about your qualitative study for N4CARE. You had a sample size of 13 older adults with dementia. Was that by choice? You wanted to have a small design to do more qualitative, in-depth work? Did you have any challenges with recruiting or retaining participants for the study?
Yeah, excellent question. This is a study that we did in collaboration with one healthcare organization. So they have a small scale facility. So there were some older adults that didn't want to participate, but in this study, we wanted to have a longer duration of the study. So it was not just one moment of data collection, but we really collaborated with the older adults I think for half a year. So from the first introduction of ourselves as researchers and the older adults as well, to really introduce on N4CARE their first expectations beforehand, and then their actual use. So part of it was strategy to really have a fixed environment and context to do this type of research, but actually some of the older adults dropped out. But it is not a major population in total as well. So.
Great. I think our next question is also about the N4CARE study. Did your design take into account the EU AI Act requirements, although they're still not enforced? And how might such regulations or others impact features and functionalities of those types of systems? And then finally, sub-question, thinking of commercial vendors and not necessarily an academic research study, what measures should be taken to protect the persons and their neighbors or friends or families, privacy, biometric signatures, prevent bias, and increase accuracy of interpretations of meaning and intent?
Yeah. Yeah, that is always sort of what type of role do you have as a researcher in this type. We collaborate closely with the developer of N4CARE, and N4CARE was first developed in the Netherlands, but also one of the best practices in Europe. So this is one of the front runners that really addresses and takes into account the European regulations on AI. It is not that we sort of had an in-depth analysis of N4CARE beforehand, but this is technology that sort of meets the conditions of safe use of technology. But I think it is really important as a researcher, and that is why it is interesting in this collaboration. The technology developer was not part of our study, but we reflected together with her, in this case, on the results of our study. So she really could take into the requirements and the ambitions of all the add-ons into account when in the further development of N4Care. And that was a great feeling for the older adults themselves. That was one of the reflections they gave back to us. Normally, as older adult with a migration background, I'm sort of the object of research, and I'm not aware about the results or what is done with the actual results. And this is one of the first studies that they participated, and they actually saw the added value of their participation and how it was integrated into the redesign of these types of technologies as well.
The next comment is from a participant who congratulates you for an excellent presentation and important research work. Is there also a demographic trend in your country of more and more solo agers, namely people who live alone with no spouse and no children? And if so, please factor such patients into yours and others' work.
I have to think closer, so thank you for the compliment at first, but I think just from a perspective, I just recently got back from holidays from the USA, but as a perspective, the distances in the Netherlands are way smaller. So I do see this trend of people getting older and thereby living alone and not having that many friends and families surrounding them. And that is something that our government addresses as well. So the social domain is really focusing on building healthy communities or strong communities to really look around for people who may not ask for help themselves. And I think that is one of the main challenges in the Netherlands as well. So I think 10 years ago, when you grew old in the Netherlands, you sort of transitioned from a house to an elderly care facility. And the government closed all these types of facilities only for the really how do you call it? The really I'm looking for the English word, like the really tough care that you have to deliver. So much more people live at home, and this is one of the challenges that we have to address as well. So how can we use technologies to first address these people who might be lonely or living alone, and then connecting through technologies or through communities to build resilient communities as well.
So you've obviously at the forefront of these technologies and AI when it comes to aging and dementia. And here in the US, we have both optimism about what AI can do for gerontology, but as you can imagine, some concerns as well. So I was wondering if you could give us your perspective, a high-level perspective as to whether you're excited or maybe excited and concerned about the next, let's say, 10 to 15 years of AI, specifically in gerontology and geriatrics.
I think the main objective is what type of, and that is the work of one of my PhD students, George Goedeveld, is what type of sort of bring back the other question, what type of data do you as a nurse need to make your work better? Instead of, we have these different types of data that is really interesting and we can integrate much more sensors, but how can we make relevant data of the AI and the collaboration with AI? And that is something that is challenging. And I think the hype of AI, for example, in decreasing administrative tasks, but also really monitoring. And at what moment should you monitor? Because you need a sort of database to get a normal pattern of people, to have these deviations and act upon it. But you don't want to intrude the personal lives of people. And how do you intrude the personal life of people with sensors? So that is interesting. And we talked about that a bit during our conference in June as well. And I think that is a sort of global questions that we really address and discuss among many nations.
Well, I want to thank you again so much for this excellent presentation. It stimulated a lot of conversation, and if attendees want to reach out further, please feel free to do so directly with Dr. Den Ouden. Again, thank you so much. I want to remind folks that this presentation will be available, the recording, in about a week from now on our YouTube channel, and you'll be notified of this. And our next webinar will be Thursday, February 13th at noon Eastern Time with Dr. Anita Ho, University of California, San Francisco, who's going to talk about AI home health monitoring for older adults, multi-level ethical considerations. And with that, again, Marjolein, thank you so much, and thank you all for attending.
Thank you so much.